Good afternoon, everyone. My name is Bo Standish, and I'm the CEO of 70 Surgical. We're very happy to have Dr. Victor Yang join us this afternoon, where he's going to be giving us his experience using the machine vision image guidance system for his cranial neurosurgical procedures. Dr. Yang, can we hear you? And can we also have you turn on your video feed as well?
Thank you so much, bro. It's glad to be able to meet with everyone virtually.
So it is my pleasure to introduce you to Dr. Yang, who is a neurosurgeon here in Toronto at Sunnybrook Hospital. And Dr. Yang, if we can ask you before we jump into the slides, if you could just introduce yourself and then please proceed with your clinical overview.
Thank you so much, bro. Yeah, so for the audience here, I'm a associate professor of neurosurgery at Sunnybrook Hospital at University of Toronto, and I also am in charge of our cerebrovascular block, providing resident and fellow education. My background is actually in optical engineering, so you can see that some of the technologies we're going to discuss today, we've had a long vision and history about it. And in the meantime, I'm going to try to bring up my presentation. And can you guys share my screen?
Now, Dr. Yang, if you hit the show,
soon, right?
It's coming through. Yep. So if you just want to start, I think
Perfect.
I'll give you a check. So we can see it clearly from the digital world here, Dr. Yang. The floor is yours.
That's great. So be very glad to share with you our clinical experience. And we've done many cases using the 70's machine vision and navigation system. The first order of business to give you some disclosure. So I have some IP, equity, and royalty. I'm also on the board of directors for 70 Surgical. So I take that with a grain of salt, but we are very proud with this association, of course. So the learning objective for today's clinical portion of the presentation is to review the true accuracy of a frameless neural navigation in your equipment. So in that, I want to share with you my experience as an optical engineer. We'll take a very critical look of your current equipment. Then we'll go over to see what's the technical benefit of using machine vision as applied to cranial navigation. And then finally, I will show you 3 case examples. These are my experience as a staff neurosurgeon at the Toronto teaching hospitals. So the first question is, what is the true accuracy of frameless neural navigation? And this is not a rhetorical question. There are times that when we register our systems, our patients, and then we say, geez, this is fairly accurate, or sometimes we say that, oh, there's a bit off, so I need to mentally keep that in mind. So when we are proceeding to the surgery, after we drape and go on under the microscope, we have to remember it is a little off. So sometimes that's a nuisance. So we are not the first people to ask this question. And I'm sure in the audience, when you wonder about that in a particular cases, there are other people who have studied this in quite detail. One of the reasonable paper that we found is actually from France, and they have looked at the Medtronic stealth station in terms of accuracy. From an engineering perspective, I want to tell you that almost 90 to 95% of the global neural navigation equipment is actually manufactured in Canada. And these are done by NDI, or Northern Digital Incorporated, and the Medtronic stealth station, Brain Lab Curve, and many other equipment. They essentially use the same backend technology. If you pay attention to my laser pointer here, is that this experiment done by our French colleague shows that the accuracy that we can obtain in the operating room is basically about 4 millimeters. The only exception they gave is if you actually invasively implant cranial fiducial markers or little screws onto the patient's skull bony surfaces and then send the patient to the CT scanner, then you can have better accuracy, about 1.7 millimeters. So this is a very interesting information because clearly that's quite different from what the regulatory approval bodies receive and what we've been led to believe. In general, we think the mean accuracy of neural navigation systems should be about 2 millimeters. But as this publication have shown you, the reality is that in the operating room, we are receiving approximately 4 millimeters. This 1.7 is quite unrealistic because in my practice, I have never placed invasive markers into the patient prior to that CT scan just for the purpose of navigation. So this begs a question. How do we really match the virtual space with the real space, which is the patient's anatomy? And what if we can actually image the real space in 3D? And that was exactly what 7D did for you. And that's what Bo showed earlier in that very quick demo. I just want to drive the point home that this is a picture taken intraoperatively for a anterior craniofacial skull-based tumor resection. And this is the entire view coming from the camera system hidden within the surgical head, almost coming from a God's view, so to speak. And that God's view is 3D. So each pixel that's acquired by that God's view has about 0.3 millimeter inaccuracy, and is taken, as Bo told you, within 0.3 seconds. That God's view allows you to actually match very closely what the intraoperative anatomy is, and that God's view can be done in very interesting things for the future. When we look at this very carefully to analyze the engineering accuracy of that, and this is a publication 2 years ago now, 1.5 years ago, it shows a few very interesting results. First of all, about accuracy. This is measured accuracy. Just like the French group have done, we measure the actual bony screw locations and compare that in the pre-op and post-op CT. That allows us to measure in detail what the real accuracy of the 7D surgical navigation system is. And here you can see that in the medial lateral plane, in the AP plane, or in the craniocaudal plane, these are about 0.8 millimeters. This is truly a sub-millimeter accuracy navigation system. And all of that is accomplished, as I'm showing you in the graph here. These are the cranial experimental system that we are focusing on, and the time involved in getting that type of accuracy is less than a minute. It's 40 seconds. A majority of the 40 seconds is actually surgeons figuring out whether they believe the accuracy or not. So with that in mind, we're gonna launch into the clinical case discussions, and we will show you some more cases that doesn't really require very detailed accuracy to begin with, and then we work our way in terms of the difficulty levels. So the first case I want to show you, which is sort of a standard requirement case, that is a typical supratentorial craniotomy for something that's a relatively deep lesion. So what we had is a 70-year-old male who had acute obstructive hydrocephalus, and he presented with nausea and vomiting. Our radiologist has gone through a detailed analysis. I'm showing you the MRI scans with multiple sequences here, and the differential diagnosis provided for us was a hypothalamic hemorrhagic lesion. And they question whether could be a cavernous malformation, or could this be a ependymoma. The reality is the patient has acute hydrocephalus and he needs a surgical resection. We brought the patient to the operating room, and here you can see is a 3D image, as I showed you earlier, taking of the patient within the Mayfield pin fixation system. And then here you can see the 7D surgical reference array placed. Here's the patient in pins, and we have a few markers, but these markers are actually placed on for historical reasons. Our CT technicians still have the habit of putting these on, but we actually don't need these at all. With the 7D system, we have over 20,000 points that has been matched, and this is a far cry from other technologies, for example, the Brain Lab or the Medtronic, which you get on the order about 100 points. So you can see there's several orders of magnitude in terms of the data that's being used by the 7D system to compute for its navigation accuracy. So here you can see if we zoom in, there are a lot of points. This is just a small area here. We have a high density of points. So with that, I also want to introduce a few interesting concepts. And here is a real-time video running through as we are verifying the accuracy of the system. Now we are touching the probe, the navigator probe on the patient's skull surface, the scalp surface. And now you can see that we're really touching the skin. We're touching the skin, and if we indent, push on it, we can try to push on the skull. But as we are doing this, we can also do what's called a planning on the fly function. And we believe that the live planning is very important, allows you to change your surgical approach as needed during the case. And later on in our Q&A period, Bo will go through that for you to see how do we provide that functionality to the surgeon. And then once the patient is draped and ready to go, what we've decided after the initial contemplation of whether we should approach this lesion in an interhemispheric approach, or should we do this through a transventricular transcortical approach. And eventually what we decided on is actually a transcortical approach. So here, what we've done is we decided to use the brain path technique, and then the 7D probe is actually used with the brain path to guide the tubular retractor in a transcortical manner, and for us to approach this hypothalamic lesion in a precise manner. So if you see the video being a little choppy, just to be aware that we are broadcasting this through. So on the navigation system, of course, this is a very fluid real-time view of the brain path portal tubular retractor getting into the ventricle and getting to where we want it to be. So once the brain port is in place, the rest of the surgery is actually very, very pleasant and very smooth. We were able to see the lesion just pooping through the foramen Monroe. We identified it immediately, and then we actually found a reasonable plane between the lesion itself and the surrounding hypothalamic brain parenchyma. So this lesion was a resected gross total, and on the right-hand side here, you can see our pre-op and post-op comparisons in a 3 months follow-up MRI. The patient had made a complete neurological recovery. And you can see this lesion is a reasonable size. It's about 3 centimeters in its longest dimension. So probably at sort of the upper limit of a small diameter brain path port. But with the navigation from 7D, because how accurately we can place the port, we were able to do this in a relatively efficient manner. So throughout the process, the probe allows us to get to the lesion with the brain port, and it also allows us to make sure the anterior posterior margin of the lesion where the attachment points are can be resected very effectively. I'll go on to our next case now. The next case is that with this first case in the foundation, now we can think of, what if you need higher accuracy? And I think the next case is a good demonstration example of sometimes extreme accuracy that's needed. So this is a 57-year-old lady. She had sudden onset headache, and in the outside hospital showed intraventricular hemorrhage. And then she was transferred to our surgery center. We performed the CT angiogram, and this is thought to have been arising from a micro AVM that is just at the foramen Monroe on the left frontal horn of the lateral ventricle. So our patient also underwent an initial attempt using onyx embolization, trying to embolize this tiny lesion. So you can see that this is the micro AVM. On the CT scan, the size of that is about 3.7 millimeters. And clearly, we believe this is a source of the bleeding. And since embolization could not completely secure this lesion, the decision was made to take the patient to the operating room and resect this micro EVM. So in this scenario, I think colleagues of ours will be thinking about how accurate the navigation system has been. Can we tolerate plus minus 4 millimeter of error? My answer will be no. I think these are the type of cases we want to be very, very careful with the navigation system in terms of accuracy. So this patient is brought to the operating room, again, very similar to what I've shown you before. And for these cases that require more of a finesse, I use a Sugita frame, and that's our go-to frame when we have a vascular case. And this is again matched with 24,000 and more points using the 7Ds and machine vision technology, provides exquisite neuronavigation accuracy. And then for the planning, again, we can use a planning, live planning feature, but we will use actually the biopsy planning software from 7D Surgical that allows us to plan a target point, and there's an entry point, and from that position, we want to approach this lesion, because the key is to recognize that we want to get to this lesion, not in the venous pouch, but actually get to its arterial supply. So this location here, in fact, is smaller than the 3.7 millimeter diameter of this lesion. And we also note that this lesion is being fed by the posterior choroidal artery, and the internal cerebral vein is right close by there. So there are a lot of features that we don't want to damage, yet we want to identify the arterial feeder to the micro AVM. So in this scenario, the accuracy requirements paramount. So again, we used a pointer from the 7D navigation system, and then we approach the lesion in a sequential, careful manner in a transventricular, transcortical technique. And here you can see the post-op angiogram comparison, and we had a complete resection of this micro AVM. So here we preserve the posterior choroidal arteries. I don't have the internal cerebral vein pictures for you on the angiogram, but I can show you on the CT scans. So on the CT scan, what you can see is that the internal cerebral vein is preserved. We see some of the onyx residuals over there as expected, but the lesion is completely resected. This patient had a 4 months follow-up CT angiogram, and she has fully recovered as well. So these two are the supratentorial cases that I selected for you, where I think there is a requirement of good neuronavigation accuracy. And then the last case I want to show you is about a postfossil craniotomy. So postfossil craniotomy had traditionally been a sore point of neuronavigation. I'm sure you remember the times that we have to kneel down, pick those points, avoid the line of sight problems with either patient's hair or the Mayfield frame being the way, and try to get the frontal features into the navigation system so you can get some accuracy at the postfossil. But usually we get inferior navigation accuracy that we want. So as a result, every time when I try to put the perforators or side cutters near the venous sinus in the postfossil, we have this automatic sphincter response that, what if we are 4 millimeters or more wrong, right? So here I want to show you, I think this is a very standard run-of-the-mill case. So she is a 55-year-old, presented with headache and nausea, and we know she has a past medical history of colon cancer about 2 years ago. So it's not was not a surprise for us to see that this lady has a sizable lesion in the postfossil, in this case about 4.5 centimeters, and it's fairly close to the transverse sigmoid sinus junction. So we can see the CT and the MRI here, and what I'll focus on is actually how do you do this case effectively, quickly, efficiently, knowing that you can use the 7D surgical navigation with a very efficient registration protocol. So our surgical plan here is to do a Lazyass incision across the transverse sinus, closer on the sigmoid junction. So it's the usual 1/3, 2/3 approach in terms of dividing the transverse sinus. So for Lazyass incision, we don't need a navigation system to mark where the skin incision should be, right? So we mark the skin incision, we very quickly prep the patient, and then you can proceed with your surgery. And the point is that once you're getting down onto the bone, then you can use the CT scan as your primary navigation data set. So in this scenario, my assistant and I, we basically retracted the flap side, and now we get about 4,000 points that is matched on the bone. And the accuracy of that is exquisite. So I just want to give you a sense of what accuracy looks like. So if you do this bony registration in a post-fossil case, then when you slide the pointers on the bone, then the pointer is exactly on the bone. In fact, if you push the pointer into, say, the lambdoid suture, or if you push it into some of the venous channel openings on the bony surfaces, then you can actually see that the navigation system is extremely, extremely accurate. The accuracy is basically sub-millimeter. With that type of navigation accuracy, so now what it means is that you can really bring the side cutter of the craniotomy near the sinus with confidence. And then once it comes to near the sinus within about 1 to 2 millimeters, then you can make a turn. So in that scenario, I think it does make the post-fossil cases much more efficient. So during cases, I don't have to show you the details of this. So clearly we can get inferior sufficiently enough to make sure that's the extent of our craniotomy, and then we just proceed with the resection. So this lady, post-operatively, her headache and nausea resolved. She had post-op radiation, and the pathology shows, as expected, adenocarcinoma metastases. And here I'm showing you the pre-op and the post-op MRI scans that demonstrating to you how close this is to the sigmoid transverse junction. And we basically resected all the way up to the inferior surface of the tentorium. So with that, we can entertain questions, and hopefully you have enjoyed this short educational presentation.
Thank you very much, Dr. Yang.